We've got an amazing panel of 988 leaders joining us. Dr. Tia Dole, Chief 988 Lifeline Officer, and we know Dr. Dole from her work with the Trevor Project, has been a longtime leader in the field. Dr. John Draper, President of Research and Development at our partners at Behavioral Health Link, been friends with John for many, many years, and Meighan Haupt, who is the Chief of Staff at NASMHPD. And Meighan, you've put together 100 NASMHPD annual meetings that we've all been involved in together, and seen a prioritization of crisis care that's a little bit unparalleled. So let's jump right in. And John, you and I have been working together on this since we first met Richard McKeon back in, I first met Richard around that 2003, 2004 period when 1-800-SUICIDE was the SAMHSA vehicle. And Vibrant brings in NASMHPD and research partners and others when the Lifeline was born in 2005. What was your hope for the Lifeline when this all first launched on the foundation of what had been laid with 1-800-SUICIDE?
Well, I did want it to become more of a behavioral health care service. I wanted people to see it as not just an assessment and referral function, not just a pathway to get traditional services, but to really be a way in which people could seek and get care anywhere, anytime, in any way that they need it. Because for so long, it was only in the traditional setting of outpatient clinics where that was the ideal place to get care. And most of those are one and done. The modal number of visits to an outpatient clinic is one. Probably the modal number of calls to a crisis hotline are one. But what can you do with that one exchange that can make a difference? And for years, it was, no, all you can do is assess and refer. That was at least the behavioral health care perspective on it. But what I'd also learned from people who've been doing this for a lot longer than I had, I started in 1996, but I was talking with people when I first started with a Lifeline who'd been doing it for many, many decades. And what I was hearing from them back in the 60s, they were reminding me is that, this was the alternative to the behavioral healthcare system, essentially, because in the behavioral healthcare system, you had to give your name. You had perhaps could get into a clinic, maybe not. You had to have insurance, you had to be able to pay for it. It had to be available. You had to be able to go at their convenience, not at your convenience. It wasn't really set up for people in crisis who really needed care now 24/7. And the way people were often treated there was not necessarily the way that they wanted to be treated. And that sense of potentially going to a hospital if you were suicidal, that was in many ways predestined, that suicidal care happened in the hospitals. So really the only way to get care that was anonymous, that was 24/7, that was at your convenience, that was less threatening to a person, was through calling a hotline. And really, while Vic was talking about us being grounded in equity, though it was not equitable back then, it was the most equitable service from the outset because it was there for anyone, everywhere, anywhere at any time. And there was no other service like that. So we wanted to take that service, legitimize it through evaluations, show it was effective in providing care, and perhaps open minds in the behavioral healthcare system to providing a different type of care for people in the way that they wanted it.
John, talk a little bit about the voices that you and SAMHSA and NASMHPD brought to the table that had not been there in material fashion previously. Because there were several.
Yeah, it actually, when we first got the grant, David, it was suggested that we have a steering committee. I had never done anything like this before, and I needed all the help I could get. And I said, actually, we need 3 committees. We need not only a steering committee, but we also need a committee that's going to help us with standards, training, and practices. And also the consumer voice was crucial for us. We wanted to get a sense from people who had lost someone to suicide or had attempted suicide or had suicidal thoughts, that tell us how to get through suicidal moments and how to reach people who are suicidal. And they were crucial voices to helping us establish national standards for crisis care.
The crisis center directors, the people with lived experience. The other thing, John, when I first saw, and we had been a 1-800-SUICIDE provider had worked closely with the American Association of Suicidology and Kristen Brooks, and they brought many strengths to the table. But the things that struck me in that vibrant proposal in 2004, 2005 was the research component, the technology. But Meighan, Bob Glover was there, and we had state mental health commissioners were the chairs for many, many years, different statement. Sharon Campanella from New York at the beginning. Talk about, Meighan, the state's focus on crisis care as this has developed over the last 20 years in particular.
Yeah, well, there has been such a concentration presently on implementing 988. I want to start there. Just the momentum around it has been astounding. And there's so much support in states right now, legislatively, just bipartisan support for 988 and crisis services. And that is unprecedented in terms of that kind of trajectory and focus across all states. States are in different places right now in terms of implementation, but there's so much good work. 20 years ago, we were looking at this issue, that issue. The peer support movement was just emerging, and it had a different flavor. It was more about surviving and surviving the kind of system that John Draper was discussing, where the care was not what they wanted. And so it was great that it emerged, and it was called the consumer movement at the time. And what has happened since is a great appreciation fundamentally for that pure voice, and that really these services can't happen effectively without peer services. To really have that relatable understanding, peer support across the continuum. The other thing that has been remarkable is, and this is specifically in the last, I'd say 8 years, is a big focus on going beyond talking about inpatient. So as John was talking about, most services, suicide treatment was done in the hospital.
Right.
We recognize now that treatment does not necessarily need to be inpatient. We want to focus on building out the community, that most people can be treated in the community. And while inpatient care is necessary for some, it's not necessary for all. And so we really want to build out that community service system. And with crisis services, that would be 988, mobile crisis teams, crisis service, crisis stabilization units, crisis receiving, with warm handoffs all along the way. And at any entry point, that warm handoff happens with clear data sharing, clear communication on all levels, including between SAMHSA, Vibrant, states, and localities, that those communication pieces are so important for this kind of growth, where we can talk about solutions to problems, and we can talk about innovations. So there's been a remarkable transformation that I think we all were looking for 20 years ago. I think we are living that right now.
Meighan, those can be platitudes at some level without execution. And you all at NASMHPD started the Beyond Beds series in 2017 to bring, I think of this as just a classic example of gentle pressure relentlessly applied, going on, what is it now, 7 years, I think, 6 or 7 years of these. Talk a little bit about that project and what you're trying to achieve.
Yeah, well, David, I so appreciate that acknowledgement that it came from NASMHPD, but really it has been such an incredible partnership across so many entities, SAMHSA, you all, Vibrant. I mean, it is now a paradigm that I think we are living and hope to continue to fold into. So essentially, NASMHPD was getting questions from the media about what does the behavioral health system need? And the media that would call NASHPD very specifically had the preconceived notion that it must be more inpatient beds. Like that, they just
had one storyline, didn't they?
Yeah, it was just like, we need more inpatient beds. So our executive director would spend an hour with the media person explaining, no, we don't necessarily need more beds. We really need to build out the community system. And if we did, it would actually prevent crisis. It would actually help people be treated in the community, and things like supported employment, home and community-based services, 988. It wasn't called 988 then, but call centers, mobile crisis teams, all of those community services. And an hour would be this long discussion about this. And the next day they would say, need more inpatient beds. That would be the headline.
Yeah.
And it was so frustrating. So, yeah, really amazing. And so our executive director said, this has got to stop. So started developing papers that really got down to, what do we need to do to build out the community service system? And so that these papers could be handed to the media. They could take it, it could be in the public domain, and quote it if needed. So to make it really clear with efficacy.
Yeah. And you've been doing that. I think there's 70 some odd papers now.
That's right.
That have our own Dr. Chuck partnered with Dr. Pinels this year on one of those key papers around the use of medication in a recovery environment. And so, Dr. Tia Dole, look, this was an amazing system emerging, but it was still, I would say, kind of boutique-ish, kind of niche-y on the side of the main system that was happening. We were here in Arizona and Georgia, where our partners are. Most calls still came through on the state crisis lines. The potential for dramatic transformation happened with these 3 digits at 988. Tell us how we went from where we were to where we're at now. How did this happen?
Well, I mean, honestly, I feel like you should start with John, because
we've already talked to John.
I know. I know. One of the things I think about is, Meighan was talking about sort of like the understanding of what is necessary and the utility of, like, the effectiveness of a conversation. So when you think about someone being in a suicidal crisis, of course, you can't imagine that a single conversation could in fact talk them off the ledge, could in fact be incredibly helpful. So I think that was sort of behind the resistance, is that someone who is suicidal has to have an extreme form of help in order to be helped. And I do think that, like, it's folks in this call, right? It's folks, on the ground, understanding is sort of destigmatizing what being suicidal means. That's my personal opinion, right? I do think that there is this notion that being suicidal makes you incredibly sick. And that's not true, right? People there's 161 people here. There are 20 people on this call who thought about suicide today, right? So if we destigmatize suicide, that means that these folks can be helped. And so I will say, there was a lot of back-end negotiation around 988. Some people wanted a different number. I think it was 611. There was like, do we put a kibosh on the number altogether if we don't get the number? And then really Congress pulled through. And then ultimately speaking, I would say the Biden-Harris administration said, okay, we're going to actually fund a thing, which has been an incredible investment in mental health and the trust that were in leaders like John to bring this forward. And so the 3-digit number, I think, maybe in my mind, took it out of just like a crisis line, and it became just an essential service, just along with something like 911. It becomes more legitimized. It's less part of the fringe. Yep. To your points, right? It becomes part of something. Talking about my mental health is not something that I can, that I don't need to pretend to take a sick day and I have a fever. I can now say at work, I'm really struggling. Yeah. I need to take a mental health day today. And I noticed that over the last few years, there's been a shift to people being like, I need a break from y'all at work. So yes, 988 was like transformative. And John and I were talking about this, I think 2 weeks ago when we were in person, is that first year, right? It was 44,000. And then the first year of 988, as a number was 5.5 million. That is a huge astronomical number. And then you look at individual things like chat and text where young people like to reach out to us. So how it happened was, I would say, so much grassroots work and then collaboration across this crisis continuum. And I do think it's the vision of folks on this room, on this call, of saying like, actually, this can matter to people, and that this one thing can actually change the lives of millions of folks who live in this country.
So I love where you started, Tia, about this connection and engagement, this human contact. So when I first started, I remember going to the Suicide Prevention Coalition of Georgia, the state leaders, and there was a clear view that suicide prevention crisis call centers were a waste of resources. The view was that truly, quote unquote, truly suicidal people didn't call them. And more people with low levels of depression and are lonely would call them. These were the views, and that if they made a difference at all, it was getting somebody connected to a behavioral health resource, not the actual engagement itself. And it was that research with Maddie Gould and John Califat and Brian Mashara and others, when they finally, SAMHSA's funding, Vibrance partnering, we've got researchers listening into calls, monitoring, measuring, asking questions. And I think even those of us who did the work were a little surprised to see that the most significant reduction in distress happened from the human engagement. We weren't surprised that people who are in very significant pain and at significant risk were calling, but I think we were surprised by those outcomes. John, those outcomes were transformative to the field in setting that foundation for not just the credibility, but for us to hone in on that work that Tia's describing. Any comments, John, on that work and history?
Yeah. Actually, I met Maddie and John Califat, who was her partner in doing this incredible work back in 2002. She came to our crisis center. We were one of the 8 crisis centers that was engaged in this definitive research, the first ever real research or evaluation being done on crisis hotlines to see if they were effective or not. And so I was really excited about the opportunity. And I felt like it was probably true. I could see that, and I felt like even the assessment and referral work that we were supposed to be doing for the city, I was thinking, even that assessment stuff is kind of helpful for people. It gets them to think about and talk about their experience more objectively, and they're also being heard by another individual, and that connection is so important. But I just didn't know how effective it would be. And so when I saw those results, and they eventually came out, oddly, my first year, within the first few months of being awarded the hotline opportunity to run the National Suicide Prevention Lifeline. So I was given the beacon of these results that said, here's what's effective and here's what could be better. And to hold that beacon to other crisis centers and say, this is what we've been looking for. This is not only legitimizing the work that we've been doing and validating it, but it's also giving us a road, a pathway to improve and be better. And it's really that evaluation and the subsequent evaluations that followed it that really justified to Congress and to the FCC that we should have a 3-digit number. So it was not only validating for us, but it was validating for the future of crisis services here in the United States. So it was huge. I got to say one more thing about what you said, Tia, that I just want to emphasize because I thought it was so important about people just not really believing that you could just reduce suicidality by talking. And it reminded me of something that my daughter said when I asked her about, and David, you've heard me say this many times, about what she thought of this three-digit number. And she had experiences of thinking about suicide before, and had been very anxious and distressed over time, and had called the line. And she said, Dad, I think it's going to do more than anything that we could possibly do to eliminate stigma here in the United States. And I said, why is that? And she said, well, there's a 3-digit number for medical emergencies, but if we had a 3-digit number for psychological emergencies, people would know that they're real, and that they could be extinguished with a very different response, a caring response, not having cops come to your door. And that, I thought, was a really eloquent way of describing exactly what you're saying, is that we provide a different response. We're not sending out, dispatching emergency services. We're not saying you need a service. We're saying, I'm of service to you, and I can help you just by being here with you right now and helping you feel less alone. I think that's such an important message that you're saying there, Tia. I just wanted to underscore that.
Yeah, we've now passed the first year mark. I think most of us were a little apprehensive, to say it lightly, what could happen in the first year, and it was phenomenally successful by almost everyone's measurement. But what are the 2 or 3 things that you're most proud of in this last now 18, going on 18 months of 988? Where have been the biggest personal highlights for you?
So I think I remember when I was on the steering committee, and I don't know if John will be okay with me saying this. I remember someone saying in there, we don't want to build a super highway into a ditch. And I was like, oh, and I thought I don't know if you remember that.
I didn't have anybody say it that way, but I had people say the same thing with
yes.
curse words and
Yes. So one of the things is I actually like to give some credit to the build that's happened along the crisis continuum. So mobile crisis teams, like not just about 988 launching and working, like actually working physically, but also like the way that other systems have stepped up in order to receive referrals, right? Because you can have conversations, but if you have no place to send people sometimes, right, then that can actually be incredibly stressful. And so there is that. I would say my favorite thing, this is my personal favorite thing that we've launched this year, is services for deaf and hard of hearing. Yeah. So we have a number of specialty
Meighan's
services.
It is.
It is? Oh, I didn't.
It is. Yep. Yep. Yeah.
Well, it's interesting because I have a background with LGBTQ folks, and I was on the other side of sort of helping to negotiate the network. But there was something about the idea of offering services and ASL in the language that folks are most comfortable in, that just, it felt really meaningful to me, and meeting the community and speaking to counselors. So that is my personal favorite over the last year, and really just kind of leaning in and making 988 accessible for everybody, and that for folks with intersectional identity to feel comfortable reaching out to us. That's like more work that we need to do in smaller communities. But that's what I like the best so far.
Look, I so appreciate each of your contributions and leadership and passion you bring to this work. And we're moving at breakneck speed, have a lot of work yet to do. And we've got about a time for a couple of minutes from each of you left. Let's look forward. As you think about how we'll know when we've arrived, what are the couple of things that you really want to focus on as we move into these years ahead to get this to the kind of service that we have with 911 and ambulances, where man, that care is strong and effective and frequently caring. But Meighan, what are you looking to as you think about the state's engagement with this and NASMHPD's viewpoint?
Yeah, so that there be that continued support, that continued implementation, that we start seeing headlines and strong examples of when people call 988, they feel like they were really cared for, and that they don't have to repeat themselves when going to different levels of care. Mm-hmm. That they feel like there is a centralized way that they personally are getting cared for, and that interaction and connection is all through the system.
Yeah, great. And it just flows. That warm handoff is not just a relational introduction. It's the passing of the challenges that, again, not having to repeat the story, and the support is seamless. John, what are you thinking about as you look forward?
I mean, we are in the embryonic stages of 988. We're only beginning to imagine what this thing could be. And as we collect more and more data and learn more and more about what people are needing right now, we're going to learn more and more about what they ain't getting and what we just don't have in our system. And I as I see more, I think, to me, what I hope to see over time that will be the ultimate, accomplishment of 988 is an integration with a behavioral healthcare system that's so seamless, where suicide and crisis care become a part of, as opposed to peripheral to, behavioral healthcare services, that behavioral healthcare services start to mimic crisis services by doing things like, you know what, maybe just offices, maybe those aren't the only place that people should be getting care. A lot of people should be getting care in their homes where they live, where the mental health problems are occurring, especially families with kids who are suffering. I think we'll see a lot more of that. I think we'll see a lot more of telehealth. We'll see a lot more ways in which AI will be used to help people in the moment. But I think what 988 is doing is saying, actually care can be at your convenience. And once we start to learn that and start demanding that, then perhaps we'll start getting it. And perhaps we'll start creating services that are provided through delivery systems that can make that work.
John, it's so inspiring. I was talking to Tom Insel a few months ago, and I think his wife had just had a hip replacement. And I would envision this weeks long, recuperation in a hospital. She was up and walking in the home with supports in the home that day. I'm like, I can't even get my brain around how they are focused on the experience of us in our lives. And why wouldn't we be doing the same? Tia, what are you thinking about as you look forward and these next steps?
I wanted to stay free. And I'll say one of the things that I think really negatively impacts mental health is when things become monetized. And so there's something to me that's really special. Like, nobody charges for a 911 call, right? You're not getting a bill in the mail or being billed to your provider. And I know, states need to figure out a way to fund this. But my hope is that by keeping things free and anonymous, we are keeping the spirit of it, which is that this is an essential service for everybody who lives in this country, and you can use it regardless of who you are, where you live, or how long it takes you on the call. And so, when you add in money, it becomes more complicated. So my hope is that we'll keep heading in the same direction while maintaining the spirit of it.
Yeah. Thank you all for all the work you're doing to make a world in which reaching out for care is easy and something that we would want to do. Keep it up. Thank you for being on today, and we'll look forward to hearing from you in the future as we continue walking down this path together.
Great seeing y'all. Thanks for inviting me.
Thank you. Thank you so much.